Now, I would like to invite our next speaker, Dr. Parul Singh. If your IOL get decentered, then the patient is going to give you a lot of trouble. So prevention always better than cure. So ma'am is going to speak about what intra steps you can take to prevent post-op decentration.
Thank you so much, sir. A very good afternoon to all the people on the chair and the hall. And I really thank AIOS for this wonderful opportunity to be in this beautiful city of Visakhapatnam. So I'll be speaking on intraoperative techniques to prevent post-operative decentration in regular phaco. We all know that proper centration of IOL is really very important, and we get clinically insignificant decentration in at least 25% of the cases, which we can go away with, but clinical significant decentration occurs in about 3% of the cases, and these are the cases that have to be dealt with care and we should avoid. So the common presenting complaints in a decentered IOL, the first one is vision. A gross loss of vision can occur due to gross decentration and dislocation, but a diminution of vision can occur in a decentered IOL due to astigmatism and the various aberrations that may happen. Loss of contrast also adds to diminution of vision in a great deal. Now the second common presenting complaint is of that photopsia. The decentered IOL gives patient negative experiences of glare, halos, ghost images, double images, and a lot of photosensitivity. So the causes to understand why we get a decentered IOL, which can be preoperative causes or the operative causes. So the preoperative causes can be a subluxated cataract when we have zonulopia, or in all the cases of pseudoexfoliation, high myopes, elderly people when we deal with large hard nucleuses, or if the capsular bag is either too large or too small. A wrong size of IOL also causes a decentered IOL sometimes. The traumatic cataract we deal with, often leading to complications, may lead to a decentered IOL. Posterior polar cataracts, as we all know, that difficult cataracts, so sometimes when we encounter certain complications, they'll end up in a decentered IOL. And the vitrectomized eyes and the silicone-filled eyes are often the causes of a decentered IOL. Now the operative causes which leads to a decentered IOL, the first is the decentered capsular rhexis. So when a rhexis is not central, often it leads us to a decentered IOL. A too small or a too large CCC leads to a decentered IOL. A posterior capsular tear, which leading to, if a vitreous tag or if leading to a sulcus fixation of IOL, is also an important cause of a decentered IOL. Any zonular dehiscence, either anterior zonules, posterior, or a total zonular dehiscence is a very important cause, we all know, of a decentered IOL. While putting up an IOL, sometimes the haptics get broken or they remain bent. A broken haptic is often a reason for a decentered IOL, which if we do not take care and we just let it go there, it leads to a decentered IOL and all those complications which happen, patient experiences. A wrong placement of IOL sometimes would also lead to a decentered IOL. As we all know that with increasing use of these aspheric and premium IOLs in today's surgery done by all able hands today, and there is loss of contrast, and which leads to decreased effectivity already. So with all these IOLs, if the glare halos of a decentered IOL add up, it causes a lot of problem to the patient. So it is our responsibility when we use these premium IOLs so that we have a very centered and good IOL. As the longevity has increased of the patient, so we need a IOL well centered for the longest period of time. So dealing few cases in which we have a decentered capsular rhexis. If you see in this case, the rhexis is not a central one. So we should, after planting the IOL, we should just not leave it like that. What we can do is, in the last video shown by Dr. Purval sir, he also mentioned it. So what we are doing is, after placing the IOL, with this microforceps, what we are trying to do is, we are trying to give a nick in the anterior capsule, and with the help of these microforceps, we are making this rhexis central. So by little effort, what we can do is, we are really making the difference in the outcome of the surgery. So this way we can make this rhexis central and not let it go as a paracentral rhexis. This is the second video in which this is a case of pseudoexfoliation, and if you see closely, that the rhexis has not started from the center. So this rhexis had since not started from the center, so we can expect that at the end of the completion of the rhexis, this rhexis would most probably not remain a central rexus. So what we can do here is, we can, as soon as we realize that we did not start the rexus from the central point, as soon as we realize, we can come back to the center, go, give a nick, and then make an effort to get it back to the center, so that now we can, even when we started our paracentral, but we can again go to the center and end up having a central rexus. In this case only, in this pseudo exfoliation case only, after we have done this rexus central, since it's a case of pseudo exfoliation and we do expect a lot of bag dehiscence, so what we are doing is, before placing the IOL, we have put a CTR ring beforehand, in this anticipation that it might be an unstable bag and we do not want an unstable bag with an unstable IOL. So after we do the complete surgery, before we plant the IOL, we have planted a CTR ring, and this CTR ring will lead into a stable bag, and we will have a beautifully scented IOL even in the case of a pseudo exfoliation. The next video is a video in which, if you see, when we are doing this irrigation aspiration, you can see that we are having a lot of flip and flitter on the anterior capsule. So this flutter in the anterior capsule, which is visible here, if you can see closely, this flutter tells us that the anterior zonules are weak. So in this case, again, to prevent the decentered IOL because of the anterior zonular weakness, what we can do is, you can see very clearly how decentered the IOL will look because of this anterior zonular weakness causing unstable bag. What we can do is, we can plant a CTR ring, and this CTR placement will end up into a very well stable bag taking care of the zonular weakness, and we'll have a centered IOL. The next case is of a zonular dialysis. This, you can see, this is a non-dilated pupil and a very hypermature cataract. So we have to be very, very cautious. We can expect zonular dialysis as well already. So first we start the surgery by placing the iris hooks so that we can enlarge the pupil. And just a second. So here we put up and we do a rexus, and in this case, after doing the phaco, you see that we see a zonular dehiscence. So in this case, we would put a CTR before taking out these pieces of cataract to make a stable bag and do not let the bag go away. Very important to put a CTR at this point in this case. Another case is again of a posterior zonular weakness. In this, just a few moments. In this case, you can see while we're doing IF, you can see there are a lot of undulations in the posterior capsule. These undulations in the posterior capsule, they tell us about the posterior zonular weakness. So again, after planting the IOL, after we realize that there is posterior zonular weakness, we can go ahead, put a CTR ring in this case as well, and get a stable bag. Thank you so much. The take-home message is, all attempts should be made to prevent the long-term decentration. Centered rexus is the key. Take care of zonular weakness and do not hesitate to use the CTR. Thank you so much.